few more minutes دكتور في عندهم مشاكل في الكونكشن few more minutes ونبدي.
That's okay. Tell me whenever you want to start.
Okay, our fellows join, so one more minute, Dr. Ayman, and we'll start. Okay, hello everybody, thank you for joining. So today is my privilege to introduce my previous colleague and always friend, Dr. Ayman Abu Mahram, graduated from University of Manitoba. He did his fellowship in neonatology there, and he did also his further certificates in informatics, and currently he's associate professor in University of Calgary. Lots of skills, lots of knowledge, especially in the quality and improvement project. And today I'm privileged to listen to him and record this session for our fellows about introduction to quality and improvement, quality improvement and benchmarking. Thank you very much, Dr. Ayman. The floor is you, and you can start.
Thank you, Yahya. It's a great privilege to be with you guys, and I'm hoping to give you a little bit of introduction about quality improvement and benchmarking. This presentation will be giving some basics mainly, and of course we can go into further details in later sessions. So other than being a lead EPIC facilitator, and I've explained to you what's EPIC. It's the evidence-based practice for improving quality, which is the quality improvement platform for the Canadian Neonatal Network. Other than that, I don't have any conflict of interest or financial relationship to disclose. The objectives of today's session is to understand the common definitions used in quality improvement, introduction to QI project development and tools, provide an overview of statistical process control, and provide useful resources for QI, and introduction also to benchmarking and benchmarking in neonatology. So a lot of you probably heard and practiced quality improvement, and you hear different definitions or terminology, quality assurance and quality improvement. So quality assurance is activities and programs intended to assure or improve the quality of care in either a defined medical setting or a program. The concept includes assessment or evaluation of the quality of care, identification of problems or shortcomings in the delivery of care, designing activities to overcome these deficiencies, follow-up monitoring to ensure effectiveness of corrective steps. While quality improvement is attainment or process of attaining a new level of performance or quality. And the graphs here that I want to show you gives you a better understanding of what we are talking about. For quality, if we look at the product, and if we look at healthcare as a product, there's a continuum of product. And here in your left-hand side, this is where, and I will use the probably laser pointer here. So in your left-hand side, you can see actually this is the lower level of quality, while here we have the better level of quality. There are a continuum between, and it's usually bell-shaped distributed. For quality assurance, they have a threshold that should be met for quality of care, and they would like to eliminate this part and to ensure all care delivered within this part. However, in the quality improvement, when you look at the bell shape here, they look at the better part and they would like to move the whole curve toward the right, toward the better quality.
Mm-hmm.
And if we look at it, this is another graph. Also, it shows the same. And here, the quality assurance, it's focused on eliminating this part, as this is what we would like to do with the quality assurance. While with the quality improvement, we focus on this better part, and we would like to move all our practice toward the better part. And I hope this graph gives you better understanding of how quality improvement work over time. And in many books and many review articles, it's called continuous quality improvement. So, well, so in healthcare, quality improvement defined as the combined and unceasing, and that's important, efforts of everyone. That includes healthcare professionals, patients, and their families, researchers, payers, planners, and educators to make the changes that will lead to better patient outcome and population, that's improvement in health, and lead to better system performance, which will actually improve care and cost, and better professional development, and here that's improved learning. So this is the triad that we are looking at for quality improvement. Why do we need quality improvement? Because there are large variations in the use of established therapies, either underuse or overuse or misuse. There is frequent medical errors, and there is a variability in outcomes from center to center, and that's observed in all settings. In defining a quality, before we go to quality, we need to know what's quality, and that's the definition from the Institute of Medicine in the United States. And you can summarize that in the word STEAM with a triple E. So safe care, patient safety comes first. Timely care, patient care will be delivered in the most timely manner possible. Effective care means patient care will be based upon the best science available or best evidence. Efficient care, patient care will avoid waste of time, money, and resources. Equitable care, access to care will be provided to all in an equitable manner. And patient-centered care, patients will participate fully in care decision. Those are important values and they should be kept in mind all the time when we do any quality improvement activity. Where and how to start? How do we do QI activity or quality improvement? A few steps that we need to keep in mind. We need to define the problem. We need to gather the team. Quality improvement is always a teamwork. We need to understand the factors contributing to the problem. We need to develop improvement aim and develop improvement plan, change management, and then evaluation. And I will go through those steps in the coming slides. Defining the issue or the problem. Identify an area where a quality gap exists. Ideal conditions for QI success. We need something that has solid evidence to inform a standard of care. We need accessible data. The gap between current and desired practice is there, so you can actually work on it. There is motivation to change or improve, and the resources to match scope of potential projects are available. You have to create a problem statement so everybody understand what the issue is. And that's very important because this is part of your shared mental model with your team. You need to describe a precise problem without suggesting the solution, using the current status and the impact of the current status, why it matters. The next step, an example of problem statement, say we have 50% of our extremely preterm infant, they have admission temperature below 36 degrees Celsius. So that's a problem that's very well defined. You have, you know your population, you know that you have half of your babies admitted in this population group having hypothermia on admission. And you need to explain why hypothermia is a problem, because hypothermia actually results in higher mortality, higher respiratory distress syndrome, risk of hypoglycemia, and other morbidities as well. So that could be a problem statement that you can use. Gathering the team. The task is complex, and no one person has the knowledge, skills, and experience to implement a solution. Change will require commitment and cooperation across units and disciplines or departments. Discuss team membership with leadership and include members from all groups who will need to participate in a change. Do not forget management. And this is important because you need all the stakeholders to be on board. Management is very important and leadership is very important to support the project, to provide you with resources. Understanding the problem. There are a few tools that's available through QI methodology to help us understand the problem. We'll talk about the cause and effect diagram, key driver diagram, process mapping, histograms, and Pareto chart here. So cause and effect diagram, it's an organizational tool that helps teams explore and display the many cases contributing to a certain effort or outcome. It's also known as the Ishikawa diagram for its creator, or it's also known as fishbone diagram for its resemblance to the bone of a fish. Ask question to identify the causes, and usually we say 5 whys. If you ask for the problem why this is happening, and after the first answer you ask another why, and usually within the 5 questions you kind of get to the fundamental cause of the issue here. This is a template for the fishbone diagram from Institute of Health Improvement that could be used. We always focus on 5 factors that could be contributing to certain issue or a problem. People or healthcare providers, could be also parents, environment, material, methods, and equipment. So we try to classify the perceived issues that could contribute to the problem into one of these categories. Excuse me. Here is an example of a fishbone diagram completed. Here, for example, a long test result, what could be contributing in terms of people, so physician order eligibly, so that's not clear. Things related to secretary, escort, things related to environment, inaccurate timing and stuff like that, things related to equipment, things related to methodology, and things related to materials, so specimens unavailable, or vials are unavailable or spoiled, lab supplies are unavailable, things like that. So in each problem, you can find what are the possible contributing factor to these problems. The other tool that we use is a driver diagram, which is basically a team brainstorming. It's a visual display of a team's theory of what drives or contributes to the achievement of a project aim. It shows the relationship between overall aim of the project, primary drivers, which we call them key drivers, and the secondary drivers that are components of the primary drivers, and specific change ideas to test for each secondary driver. Here is an example of that. This is also an example. The overall aim here is to reduce by 50% colonization and infection with MRSA by August 1st. So you have time, and I will talk about the smart aims later. Primary drivers here is reduce transmission of infection and colonization, and here the other one is reduce infection once colonized. And then you have a group of secondary drivers and what change ideas that could lead us to a secondary driver. And it is nice once you develop the driver diagram is to have it posted somewhere so everybody understands what we are trying to achieve. Here's another example from neonatology. For example, we aim to decrease delivery room intubation by 10% within 12 months. The primary driver is improve face mask post-pressure ventilation and improve the team buy-in. The intervention that's used here use end-tidal CO2 detectors, round mask during a face mask positive pressure ventilation, increase the PIB pressure, increase the eye time, and simulation-based training. And for the second primary driver, we are looking at review evidence and retrospective data, debrief of DR intubation by the physician, and update of progress in resuscitation conference and small group meetings. So those are examples of how you can develop a driver diagram and how you can get to share that with your team. Process mapping is another thing that is sometimes very useful in quality improvement. It's a visual representation of the sequence of steps in a process. It helps the team to have shared understanding of the process and identify the steps that do not add value. You need the right people in the room as well to identify all steps. And it amazes me every time we put a process map, you identify many small steps that you never think about. So it is, although sometimes the process might look simple, once you put it in paper, you identify small steps that's actually frequently not realized. And those small steps that actually could change your process significantly. So start by defining the first and last step in the process. May use sticky notes if you want to use a flip chart or a whiteboard, and start with a simple flow chart and go from there. And one of the tools that we use also what we call a swim lane diagram. And here's an example of a process that we developed for our extremely low birth weight babies admission process from the delivery room until they are stabilized in the NICU. As you can see here, we use the swim lane diagram, including the individuals and what task they do simultaneously and consequently. And as you can see, I never imagined it will be that complex. Other tools commonly used also is called histograms. And histogram is a special type of bar chart used to display the variation in continuous data like time, weight, size, or temperature. It enables the team to recognize and analyze patterns in data that are not apparent simply by looking at the table of data or by finding the average or median. And that's really, really helpful to look at the histogram. And I'll show you an example here. This is a histogram of admission temperature that we developed in one of our projects. And basically here what we put at the temperatures in the x-axis and the number of subjects in the y-axis. And as you can see, we have almost bell-shaped distribution, and it tells you where the majority of patient falls and where's the minority and the outlier fall as well in this diagram. And that gives you nice visualization of your data, while if you look at it as a table format, and then as you can see the numbers here, we are talking about more than 300 patients in this data. When you look at the table, it's not quite helpful and doesn't give you an idea, but here we can identify how many we have in this range and how many patients we have in other ranges as well. The other tool is called a Pareto chart. And Pareto chart is a different representation of the reasons for the problem. And actually, Pareto principles, it's also called the 80-20 rule. I'm sure many of you have heard that. And this means that in any group of factors that contribute to an overall effect, roughly 80% of the effect comes from 20% of the causes. And here, for example, in this table, you can see types of error discovered during surgical setup. This is an example. They looked at they counted the error that's occurred, and they have the frequency, the percentages of each type of error. Example include wrong supply, excess count, too few counts, wrong size, wrong sterile instrument, and so on. Again, looking at the table itself is not that helpful. If we look at the Pareto chart And when you actually put the contributing factor in x-axis from the highest count to the lowest count, and Pareto line actually that's the cumulative percentage of events. And as you can see, you have those, what we call them vital few. Those are the three factors that's contributing to almost the majority. And if you can see, here's the frequency, here's in the other y-axis, the percentages. Three factors actually contribute to about 73 to 75% of the causes of the errors. And there are other factors, what we call them useful many, that you can work on them later. And that actually helps you to identify where are the issues that you need to focus on and where to start. And then this is really an important aspect of planning your QI project. And QI also, we look at model of improvement, how you can go from there after you identified your issues. The model of improvement includes the BDSA cycle. This has been there for many years. Many of you have used it or have seen it before. And that's focus on those three questions. What are we trying to accomplish? How will we know that a change is an improvement? And what change can we make that will result in improvement? And BDSA cycles, because we call them cycles because you don't stop at some point. You plan, you do, you study, you act based on your changes that you have made. Then you plan again and you do the change, study it again and act, and it goes so on. And it has a cumulative gain. So that's why it becomes like, consecutive BDSA cycle as it's shown in the other graph here. The elements of BDSA cycle planning, including planning, you need to state the objective, make predictions, develop a plan to test change, and who is going to do it, what, when, where. Try to be specific so everybody knows exactly their rules. Identify what data will need to be collected. So, and you carry out the test, document observation and problems, collect and begin to analyze the data. Then you study this data by completing analysis, compare data to predictions, record conditions when the result could be different, summarize what you have, and then after that, adopt and adapt. Adoption and adaptation are really important here, or abandon some practices as well, and build your knowledge based on your previous BDSA cycle. As you can see here, although in the previous graph we put each one of these steps is a quarter, in this graph you can see the planning is taking probably half of your time. And studying is taking another quarter, and acting on it, this is another quarter. And I think the better the planning, the better the outcome. And any project that you want to do, it's a principle in project management. If you have good design, good plan, likely you'll have better outcomes from this project. So don't think the time that you spent in planning your project is wasted time. It's absolutely worth investing. Planning QI project, we talked about the problem statement. After you do your Pareto chart, you do all what you need, you have to define a SMART aim. And SMART the acronym has been there for long. Your aim has to be specific, measurable, attainable, relevant, and time bound. And that's actually helped to keep accountability, help to have a clear vision with all the team members, and everyone have a shared mental model of what you are trying to do. One of the things that you want to do during planning as well is to say, how am I going to measure my QI activity? There are three important types of measures in quality improvement. One of them is the outcome measures. The other is process measures and balancing measures. I'll explain those in the coming few slides. The outcome measures is actually the key things that you are looking at. The outcomes of the QI project is aiming to improve. This is what you would like to achieve. The outcome measure is related to your SMART aim. This is the main thing. It could be one or two. Try to make them a small number of outcome measures so people are quite focused on what they would like to achieve. And how does the system impact the values of patients, their health and well-being? What are impacts on the other stakeholders such as payer, employees, and other community? Examples: admission temperature, um, intraventricular hemorrhage, bronchopulmonary dysplasia, or neck rates. Those are outcome measures that you are looking at. Process measures, those are the steps or metrics that lead to the desired outcome. This ensures that the QI project is implemented as planned. So the process measures, say if we would like to change the process to improve admission temperature, we decided to have every baby is born below 32 weeks to have plastic bag cover them in the delivery room. You need to know actually, after you put this change in, how many baby actually had a plastic bag in place. So that's what we call process measure. Are the parts or steps in the system performing as planned? Are we on track in our efforts to improve the system? So that's important. Examples here include proportion of delivery where gel matrix used, and proportion of deliveries where delayed, or what we call here natural cord clamping eligibility reviewed. Balancing measure, and that's an important factor that's frequently missed in quality improvement. Sometimes we would like to ensure that the metrics that must be, it's a metric that must be tracked to ensure that an improvement in one area does not negatively impact another area. Example of that, implementation of early extubation guidelines. The balancing measure will be for that is the reintubation rate or extubation failure rate. After you have all this, you go to the implementation, and that requires understanding of the change management strategies. And this graph is the diffusion of innovation graph. It's developed by Rogers, old concept since 1962. He has a book called Diffusion of Innovation. I would recommend it to everyone to read. Also, another book recommended related to change and the diffusion of innovation is called The Tipping Point, and a nice book and shorter book to read, actually. As you can see in this curve, there is people who adopt a new technology or a new technique or a new practice very early. We call those are in the innovator, the ones who invented this. Then you have after that the early adopters, people who like to try new things. Then you have the early majority and the late majority, and always you have laggards who don't want to change anything. They want to stay with the old practices that they have. And as you can see, you reach your about 50% when you hit your early majority, and that's actually where the change or the innovation becomes more acceptable as the new norm at this stage. So you want to achieve this early majority as soon as possible for any QI project. This is another theory about the change management by Borshaska and de Clement. People and their acceptance for change, they go through this 6 stages. Pre-contemplation first, which is no intention on change and behavior. They don't know there is a problem, so you need to achieve that first realization. So contemplation, they are become aware to the problem, that now they realize there is an issue. That's something you need to work on to get people to understand what's the issue. And here when they realize the issue that exists, but they are still not committed to change it. They know we have a problem, but you know what, we have been doing this all the time. I don't know what to do. Then you move to preparation stage, where there's an intent on taking action to address the problem. They don't know exactly what it is. And this is your role as a QI lead to actually guide them in adopting those actions that you will present. Here, people to move to action, where they do active modification to their behavior. And after that, you reach to the maintenance, sustaining the change. The new behavior becomes the norm and replaces the old behavior. And frequently, we could see relapse where we go to old practices. And a very good example of this issue with relapse that requires continuous work in maintenance is hand hygiene. With hand hygiene, you need to make sure you need to boost your hand hygiene rate so people will know exactly if they have deficiency, they are not meeting the target of hand hygiene practice during their care that they provide in the NICU. Then you propose changes, they take action, they maintain it. And if you kind of leave that alone for sometimes, you will frequently see relapse and your hand hygiene rate drops and probably your hospital-acquired infection rate increases. After that, we move to evaluation. We have to, in the planning stage, we put what measures we would like to see and how we evaluate those data. And that's, we will talk about QI data analysis. Remember, QI, I have seen many QI projects, great, people are motivated, hardworking, they put a lot of effort in place, but they haven't spent enough time on collecting data, analyzing data. And then it becomes hard if they see change to know, is it due to chance? Is it due to their quality improvement? And the worst case scenario, when you actually have unintended consequences and you cannot identify why this happened. So that's why it is with every QI project, you should have good plan for data collection and data analysis. For quality improvement, we use what we call statistical process control. It is actually an industry-driven process and standard methodology for measuring and controlling quality during the manufacturing process. Quality data in the form of product or process measurements are obtained in real time during manufacturing. This is where it started. And healthcare, I would say, is late adopter of statistical process control, which is in other industries has been there for many decades, actually. We use few charts, and I will talk about two of them only today. One of them is called run chart, and it's a simple display of data over time with a median line that indicates the central tendency. Run charts help improvement teams formulate aims by depicting how well or poorly a process is performing. They help in determining when changes are truly improvements by displaying a pattern of data that you can observe as you make changes. They give direction as you work on improvement and information about the value of particular changes. There are few rules for run charts, and by no means this presentation will cover all the statistical process control, but some idea I will give here. One is called the shift. So it means 6 or more consecutive points, either all above or all below the median. Values that fall on the median do not add or nor break a shift. So as you can see here, when you have during this time, say this is the x-axis is the time epochs, if we consider those months or weeks or whatever time epochs you use, and this is the measure of characteristic count of patient, for example, or percentages. And as you can see here, you have a shift. You have with this process. Frequently, we see random variation where the numbers move up and down around the median line. But when you see consistently that you have 6 values above or 6 values below, that tells you there's actually something happening that's leading to this change, and it could be your QI activity. Rule number 2 is the trend, which is 5 or more consecutive points all going up or all going down. And that doesn't matter if they cross the median line. Here, if the value of 2 or more consecutive points is the same, only count one of them. The first one is count and the other one is ignored. And that we call trend. So when we see this, we know that we have trends for increase. Then something happened here, led to decrease. Then we hovering around the central, the median line. Then you have a trend here, downward, and again going up. That's where I'll show you the relapse happens. Rule number 3 is what we call runs. And the run is a series of points in a row on one side of the median. So it's basically how to calculate the runs. It's the number of runs equal the number of times the line connecting the data points crosses the median plus 1. So in this chart, it crosses 1 time. So you have 2 runs. This is 1 run and this is 1 run. If we go back to our previous slide, you have here 1 run, 2, another 1. and here multiple point crosses the line, and then down, up. And actually, to show improvement, you would like to see a lower number of runs. And you have sometimes what we call astronomical point, which basically it's an outlier here. It's a data point that is obviously different from the rest of the points. All studying the chart would agree that point is unusual. Astronomical points should not be confused with the highest or lowest data points, which every run chart will have. Sometimes you might have this due to an external factors that led to significant deviation from what you expect to see. The other type of chart I want to talk to you about is the control charts. And control chart is a statistical process control tool used to determine if a manufacturing or business process is in a state of control. It helps teams distinguish between common and special cause of variation within a process. The common cause variation, the variation that's expected by chance in a stable process. The special cause variation, it's a variation that would not be expected by chance in a stable process and is an indication of a changed or unstable process. The component of the control chart, as shown here, we have an upper control limit. So the line calculated at 3 sigma above the central line. 3 sigma means 3 standard deviation. And a line chart of data measuring the process over time. This is what we see here. Center line calculated as the average of median of the data. And as you can see it here, and lower control limit will line calculated at 3 sigma below the central line. Control chart types, we have what we call B chart, which looks for proportion. U is count, this is for counts, which is for rare events. And we have types called XMR and X bar S charts. And X bar S more used actually for continuous variable if you want to use, for example, temperature or time to achieve certain outcomes. Here, there is various distribution of data with the control chart. We have a single point outside the control limit that indicates that we have actually a special cause variation. We have a run, 8 or more points in a row above or below the limits, and 6 consecutive points increasing or decreasing. This is a trend, as we discussed. We have 2 out of 3 consecutive points near or outer 1/3 of control limits. That indicates also special cause variation. And this, when we have 15 consecutive points close or inner 1/3, so within 1 standard deviation, that tells me that the process is in control. This is an example of our one of our control charts, which is TBN parenteral nutrition initiation within less than 60 minutes of admission for babies born 23 to 31 weeks. As we can see, we have, before we implement cycle 2 of our golden hour, we have a median of 47%. We have quite a bit of variation. Then once we implemented that cycle, we improved our median from 47 to 65. We have some data above this new median. And then we have a little bit of running down, and when we end up, if we get the median of everything, we could have actually significant number of points above the median line here, and that indicates special cause variation. The other point I would like to talk about is reporting your QI work. And don't forget that. This is really important because after you do all this work, it's worth publishing. And one of the standards to publish QI is called Squire 2.0. And it's a very nice article that you can look at, and look at the component that you need to put in for your publishing your quality improvement projects. We'll talk about the benchmarking, and this is the second part of my presentation, is the continuous process of measuring products, services, and practice against the toughest competitors or those companies recognized as industry leaders. And this is really important. When you do healthcare, you need to have some benchmarking to others. And I'll talk about the types of the other definitions used, the process of identifying and learning from good practices in other organizations. In healthcare, there is a Joint Commission and Accreditation Health Care Organization in the United States. I'm sure you have seen that. And outside the United States, they call it GCI. And they define benchmarking as a measurement tool for monitoring the impact of governance, management, and clinical and logistical functions. Types of benchmarking: internal benchmarking, competitive benchmarking, functional benchmarking, and generic benchmarking. Internal benchmarking include the comparison of internal operations to other internal operations inside the organization. For example, comparing hand hygiene rate between neonatal intensive care unit and pediatric intensive care unit and OR, for example. It's the easiest technique to start with. Some disadvantages in that it actually may not be as good as the performance of a competitor. So we are just comparing among ourselves or within our family. Competitive benchmarking is a direct competitor-to-competitor comparison of a product, service, process, or method in the same industry. It helps you know yourself, know your competition, and incorporate the best and gain and maintain superiority. Functional benchmarking, that's the comparison of similar or identical functions across different industries, useful for products or services-oriented activities. The key is selection of an appropriate partners to compare with. And there is generic benchmarking, which is comparing generic business processes across a wide cross-section of industries. For example, comparing payroll or purchasing activity, inventory management, in healthcare and in aviation industry. That's called generic benchmarking. In Canada, we have the Canadian Neonatal Network, which is a group of Canadian researchers who collaborate on research issues related to neonatal care and quality improvement as well. It was founded in 1995. Currently, we have 31 centers, 2 of them in the United States, actually, including 18 universities. We have standardized NICU database, all infants admitted to level 3 NICUs, and the focus mainly on the infants born at less than 33 weeks gestation. And this is the website for the Canadian Neonatal Network. You can actually access our annual report freely through the website. Benchmarking in neonatal care, we have known to everyone Vermont Exford, which includes many centers in the United States and outside the United States. NICHD, which is Neonatal Institute of Child Health and Development, and they have the Neonatal Research Network where they compare some academic centers in the United States. California has a very nice collaborative for QI in perinatal care, and it's called the California Perinatal Quality Care Collaborative. I would recommend visiting their website. They have very nice work there to review. Australia and New Zealand Neonatal Network as well, Neonatal Research Network in Japan, and the UK as well. And led by Canada also, we have the International Network of for Evaluation of Outcomes, what we call INEO, which is actually connect the data from 10 different national networks from 10 different countries and compare outcomes. They have very nice publication that you can find online as well. So in summary, QI is a systematic approach to improve and optimize care. Engagement of stakeholders is a key for successful QI. QI practice require basic knowledge of QI methodology. QI initiatives must track appropriate measures. And don't forget to report your QI work and benchmark and learn from others. This is another key factor in your success. And I hope that you, I think in Emirates and Gulf country, you easily can develop a network where data could be collected from different centers and compared and benchmarked. We need to remember that QI means strive for a safe NICU journey, and that includes all those professionals. Remember, don't forget anybody from your team. to be included in quality improvement, because each one of them contribute to the better outcome that we look for. Some resources here: EBIC, which is the QI arm from the Canadian Neonatal Network, evidence-based practice for improving quality. Multiple publication out there from EBIC. You can find them on the internet, and if you're interested, I can send those to you. We also offer a quality improvement workshop, either 4 hours or 6 hours, to understand the principle of quality improvement and how to develop a QI team and QI initiative. Also, through University of Calgary, there's Certificate in Patient Safety and Quality Management. This is an online certification. You can obtain it regardless of your location. And also, the Institute of Health Improvement offer the Open School. This is paid courses that also you can enroll in online and learn about quality improvement. And thank you very much, and I'm happy to take any question.
Thank you very much, Dr. Rayman. I don't know if you hear me.
Yeah, I can hear you very well.
Yeah, so wow, very heavy, not easy. Amazing job. Thank you very much. So you have a question from Dr. Sarah, tells you, can we have a copy of this presentation?
For sure, I can send it to you.
Great. And Dr. Arula is asking you, can we apply the result of one institute to another institute? I know the answer will be no, but I'd be there any mean of making use of data to implement?
Absolutely. Actually, one of the things that we do with the Canadian Neonatal Network and EBIC is to learn from each other. You might need to modify, first of all, you need to understand the data from other institutions. And you need to have a conversation with it. You cannot just take the data that's published and use it. Best way to do the quality improvement in collaboration with other institutions, and if within a collaborative, for example, the Canadian Neonatal Network or the California Prenatal Care Collaborative, is to have regular meeting with other institutions, try to understand what you are, how they did that, and what was their problem. Is it similar to your problem? Are you able to achieve the same? And try to adapt and adopt the process to your institution. You might need to tweak it and do it differently a little bit, but definitely you can learn from others. That's the whole purpose of QI.
Dr. Hadi, thank you very much. Dr. Hadi is asking you how to elaborate a quality improvement question that will work and then work on it for changes. I think that he meant that how we generate or make the question.
So first of all, if you remember, I mentioned about the problem statement, and this is the key. You need to identify what is the issue that you are trying to improve. For example, and that's where benchmarking help. So an institution has a mortality rate for babies less than, I would say, or in babies who are born between 24 and 28 weeks gestation, the mortality rate in one institution is about 30%. In another institution, or what's reported in the literature, is about 20%. So here is a problem that we have. We can say that we have here our mortality rate is higher than what is reported in the literature, or higher than our neighboring institution in the same country. So we aim to achieve, then your statement problem is the mortality rate in X institution is 10% higher than average. So that's your statement problem, and that's based on your measures compared to a standard.
Okay, great. So is there another ways of generating question other than benchmarking?
Of course, standard of care guidelines. For example, we know that from LCOR that normal temperature for a newborn infant is 36.5 to 37.5, and there is a recommendation to maintain this temperature. You need to collect baseline data to see, for example, what is the admission temperature of your babies? Do they, how many babies what's the proportion of babies in your institution they have hypothermia on admission? So that's a way to create a statement problem. Other way of that, for example, a patient with hypoxic ischemic encephalopathy undergoing therapeutic hypothermia. You want to achieve temperature within a certain target, 33 to 34 degrees, for example, and you want to know how many, during the 72 hours, how many times the babies actually become outside the target temperature, how many times the patient become below or above the target temperature. So that indicates your ability to maintain the therapeutic hypothermia within the 72 hours. Those are simple examples of how to generate question. Example, patient with hypoglycemia identified, or critical hypoglycemia identified, how long it takes you to normalize their blood sugar or to establish IV access. Things like this actually might be helpful to generate question, and you might need to have some baseline data to be able to do that.
Okay. Are you okay getting more questions or?
Sure, yeah.
Yeah, so the question is, can a quality improvement project of a different unit or of a different level of unit, like an ICU and a step down level, be applied to each other and vice versa?
Absolutely, you can. You need to keep in mind when you adopt a quality improvement from other institution, you need to adapt to your unit. So you need to, again, talk to them and see what's the goals and how they achieved it, what was their problem, and try to modify this this project to suit your institution. For example, here, when we adopted admission golden hour checklist for extremely low birth weight infants, our sister institutions here were level 2 in ICUs. They wanted to adopt something similar for their population, which is 32 weeks and above. Of course, the checklist has been modified to suit their purpose. So you can always learn from others and try to make it work for you.
Okay, so the question is, on which page we select the diagram to present the quality improvement project? Is there like a specific question for each diagram, or all the diagram can be applied to any question?
All the diagram could be applied to most of the questions. You need to know if you have continuous variable versus categorical variable, that's count. So if you have a count, you need to look at percentages. If you have a continuous variable, you have to look at histograms with specific bins or groups where you can actually plot the data within those groups. So there are various ways of looking at it. And Excel is a great tool. You don't need this very complex tool to present your data. You can use Excel. And there is an add-on to Excel called QI macros. It's a paid add-on from the United States, but it is a very useful tool that you can develop the QI chart using that tool. And you might check with your institution. Many institutions actually have it available. They buy an institutional license for it.
Okay, thank you. So the other question is all the measures or type of measures are applied to all type of diagram presentation of the quality insurance question?
No, you need to, for example, as I presented, when you select your control chart, there are different types of control chart based on your outcome. So there are types of control chart for continuous variables. There are types for categorical variables that's presented in proportion. And there are different types, which we call Q chart, for rare events, which, for example, you look at incidence of poor outcomes at different points. So you look at it over a longer period of time. So that's something that you need to develop skills around how to use QI. So that's why I actually look at QI as it has a science in it, and it might be in each team to have somebody who spend more time learning the QI skills and taking some QI courses that will be helpful for them to apply those tools and guide their team through any QI projects.
So the last question is, what is the best way to deal with the diffusion of innovation, the late majority and the ledgers?
That's a very good question. It is hard as well. One of the things that you need to bring people resist change because lack of realization sometimes. So there are different ways that you need to look at to bring different groups to realize what's the problem. And sometimes you need to show them that the solution is there and it exists, and others were able to achieve it. And try to have champions among each disciplinary of care, among each group, who can actually help you to disseminate the idea and the good science and the new practices. And be patient. It takes time. I can tell you sometimes some changes may take a year or two to achieve the majority accepted, and you still have some laggard at the end who's not going to do it. But while you have the majority is doing it, I think at the end it becomes the culture and everybody come along.
Okay. Well, I think I have all the questions. Thank you very much. It's very heavy, not easy for somebody who is not aware of it or is not practicing it. Need lots of probably rehearsing so to digest all that. Thank you very much again. I really appreciate your time. And I know it's probably late afternoon in your time, right? Or it's still morning?
It's 10 a.m. here.
Oh, okay. So I know you're very busy. Thank you very much for dedicating this for us. And I hope we can see each other. And you have many thanks from different people.
Thank you.
Dr. Hadi, Dr. Jean, Dr. Rula, and of course me. Thank you very much again. I really appreciate it. Dr. Ayman is very approachable. If you need help, I'm sure he can provide you with any quality project. And he's a great teacher and very helpful person. And he's a great friend of mine. I always can ask him for help, and I hope, and he will be providing help for any one of you.
Thank you very much, Yahya. I appreciate that, and thank you for inviting me. And I will send you the presentation and my email as well. You can distribute to the attendees.
Great, and I have the presentation on my tube for anybody who want to review it.
Okay, take care, and have a good night, guys.
Good night, take care.
Bye.